Hello, I'd like to welcome you to the RAD 1226 class on tomography. Well, as you can see in front of you, you have a nice CAT scan machine. Very pretty looking, but how does it work? Well, there's a lot that goes into tomography, and tomography does not have its beginnings with CT machines. It actually comes quite old in terms of how long it's been in the radiology field. And some things remain the same, like the X-ray tube. Always an X-ray tube. End of introduction. Okay, well, when it comes to tomography, let's talk about firstly what we're going to talk about. First, we have to talk about what is known as conventional tomography, because CT wasn't always around. We'll talk about why it's done, some of the basic principles that make it work, why the X-ray tube motion has anything to do with tomography, the selection of a slice, some of the applications that can be utilized, things to think about when it comes to dose. Then we'll get into our modern computed tomography, and we'll talk about some of the basic principles. Well, what is our rationale? Well, in tomography, the idea is to produce a section or cut of the body. Generally speaking, when we take an X-ray, for example, the spine, we need to go through the entire body with radiation, the tummy, the organs, everything just to get to that spot. Because of this, our contrast goes way down. We have to shoot through all of this other tissue just to get to the area of interest. What if there was a way to isolate an area of interest? Well, that's the rationale behind tomography. The idea is to isolate a section of the body, let's say 3 inches anterior from your back, going towards your belly button, without getting anything else in the image. The idea is that structures outside of the area of interest will be blurred, and that the area of interest will be clearer than if you were trying to look at it just as a normal routine radiograph. The way this is accomplished is by moving the tube and the image receptor in opposite directions, and the patient really has no part to play here because they are stationary lying on it, what's usually a normal X-ray table that has been retrofitted with the tomography equipment, allowing the tube to arc over the patient in this manner. If you notice over here, tube is going in one direction to the left, and down here, tube is going, image receptors to the right. In the center is what's known as the fulcrum. The fulcrum, or pivot point, is an imaginary place in space. However, it adjusts the tube and will allow us to take different depths or cuts within the body. So this fulcrum is something that we set based on what a radiologist particularly is interested in. And generally, you don't just take one cut, you take several. One of the traditional exams that tomography was utilized quite often in is the IVP, or the intravenous pyelogram. And this was an examination for the kidneys where contrast was injected to look at both kidney function, the ureters, and ultimately the bladder. So as you can see here, the tube and the film rotate around an area which is known as the fulcrum. And this fulcrum is generally determined by a scout image, and in that IVP procedure, the radiologist would say, I would like cuts 8, 9, and 10, or 10, 11, and 12. And these were usually defined technically in centimeters. Each one of those cuts, or setting of the fulcrum, defines the plane which will be sharp in the image. Well, at least sharper, because as you'll see, as we did on the last couple slides, that some of these images seem like they're blurry. The reality is you cannot get that sharp of an image in traditional radiography, at least not until we have gotten into computer tomography or CAT scan. The tomographic angle is the angle between the different CR positions at the beginning and the end of your exposure. And while the fulcrum defines your slice location, the tomographic angle defines or controls your slice thickness or cut. Tomographic angle has an inverse relationship to slice thickness. If your tomographic angle goes down, as indicated by the purple arrow, you get a thicker and thicker cut. The motion of tomography, although if any of you are familiar with it, you have most likely seen linear, which we saw on the slide. But at one time, tomography consisted of many different types of tube movement. Some are very complex. Some of these included circular, that we have over here, tri-spiral, figure 8. And the idea is that some of these would reduce some of the artifact or streaks that would occur along with your blurring. End of part 1. So, as you can see by this next slide, when you adjust the tomographic angle, you can see that here we have a larger angle of 60, and here we have a smaller angle of 30. But take a look at the slice thickness. It's almost twice the size here, and perhaps it should be twice the size, as the angle is exactly half that of the previous angle. If you take a look here, this is your traditional setup. The only thing that looks different that you might be able to tell is here you have a small panel which allows you to adjust your fulcrum. There's a knob in the back, and here is basically a metal bar that will allow this arc to take place across the tube. And you can't quite see it, but underneath the table down back in here is another mechanism that will allow the bucky to flow in the opposite direction of the tube. Now let's move on to a modern computer tomography unit. We are still talking about sectional images, so cuts of the body. And basically, when you compare a 14 by 17 KUB radiograph, think about this. You have 17 inches of open collimation. And we all know that if you increase your collimation, make your field size larger, you will get more scatter. That being said, if you take a look at a Tomo cut or CT cut, the slice thickness may be a millimeter, maybe even less. Because you are taking such thin acquisitions, you will automatically get a huge boost in contrast resolution due to a massive decrease in scatter. In addition to having a nice thin cut and reducing the scatter, improving the contrast, your X-ray tube is not stationary, except for perhaps the scout image with which you use to plot your other images. Essentially, your tube is spinning around, and while it is spinning, it will be taking projection after projection of data. So when we do a normal radiograph, how many projections are there? Well, one. If we do an ankle radiograph, we may take 3 views, but each view is just one set of projection. In a CAT scan, if you think about a second hand going around and you freeze it, so you have a tube on one side, and instead of an image receptor that you're used to, you would have a set of detectors. They will be making transmission measurements or attenuation measurements of the tissues that are traveled through approximately 1,000 times. About 3 projections per degree of rotation in a 360-degree circle. That projection data is then manipulated into just one image. Yes, we're talking about 1,000 sets of data turning into one slice. And then multiply that by the number of slices you may have in any particular study. That image is then reconstructed, sent to a specialized computer, which we'll go over in a second, and then finally onto your monitor screen for your viewing. By doing this, by getting a cut and improving our contrast resolution, we are now able to see many, many more types of homogeneous objects. In other words, objects that have similar mass, similar densities, that regular radiography is unable to visualize. Essentially, it disappears, or the grayscale that is attributed to 2 different objects remains the same, and you can't tell the 2 from each other. So we get rid of a lot of the superimposition. We get rid of structures that are lying on top of each other, and we are able to isolate a cut or thin slice of the anatomy. In regular X-ray, we have poor soft tissue detail. We can approximately see the difference between objects roughly at about 10% or more. So if there is a small difference between one object and another, let's say only a 5% difference, we're not going to see that. Whereas in CAT scan, we can see very small attenuation differences that are less than 1%. Believe it or not, that may sound good, but that is a world away from nuclear medicine, where we are seeing objects at a molecular level that show up as a hotspot on an image that would never materialize on a CAT scan. If we take a look at this image here, here is our X-ray tube, and here are our sets of detectors. With these detectors, you can see that you have 4 rows. 1, 2, 3, 4. If we spread our beam of collimation across these, we also have the ability with CAT scan to take multiple slices simultaneously. So in this case, for each time that the CAT scan moves around the patient's body, we would get 4 simultaneous slices. Well, we all know about Rankin back in 1901. CAT scan is a relatively new modality. 1979, Godfrey Hounsfield and Alan Cormack, they also received the Nobel Prize, and they are responsible largely for creating what we know as the modern CAT scanner. If you take a look here, back in the 70s, we had some pretty basic looking computers. The actual prototype scanner didn't even spin around, right? It was tested on a piece of brain matter purchased at a butcher shop in London, and it took a very, very long time to scan this, something that a human person could not possibly be able to sit still for. And I believe the reconstruction took approximately 6 hours. We are down to less than a minute on reconstruction for the most part. In 1974, Dr. Robert Lilly develops the first whole body scanner. So the scanner that Hounsfield and Cormack worked on was a head-only scanner. And it turns out we've somewhat come full circle because there are now portable CT units that can be utilized almost anywhere. I even saw one in a German ambulance, but the one that they have at some of the hospitals we affiliate with can go up to the ICU unit. And in those cases, those units are head-only scanners. That's what I mean by coming full circle. But Robert Lilly develops the first whole-body scanner. Now, the future is coming very quick. In prototype now, I believe there might be two in the world being utilized. Siemens has come out with a 640 slice scanner. This will cover 20 inches in one 360-degree arc of rotation for your tube. What this means is in less than a second, because that's about how long it takes to go around one 360-degree circle, you can get 640 individual, very thin slices, probably upwards of about 0.5 millimeters per slice. You can try to figure the math out based on 20 inches of coverage. So the future is now. 320 is already out there. I just mentioned 640. And for the record, you can probably take a guess how these things work in terms of slices. You start with 4, you go to 8, then it keeps doubling and doubling. Many of the scanners that you might be utilizing out there are still 64 slice scanners. We've moved on to dual source scanning, where you actually have 2 X-ray tubes. And we've continued to increase our coverage of anatomy in what's known as the Z direction, going from head to toe. So, if we take the basic principles of CT and go over them step by step, you'll see, at least at the very beginning, it sounds a lot like regular X-ray, because it is. At the beginning, our X-ray beams pass through, well, in this case, a cross-section of a patient's body, and we are still going to be collecting attenuation data, except instead of via a screen film and the changing of clumps of silver, we're going to have these signals coming out of the patient, photons, and they will be collected by a set of detectors. But before we even get to that, our beam is collimated. As we talked about earlier, our thicknesses of collimation are less than a centimeter in most cases. So that's going to reduce scatter and automatically give us much better contrast resolution. So our collimated beam is going to pass through the body. We're going to get differential absorption. Different tissues will absorb the beam to more or less degrees than other areas of the body. And ultimately, some of that beam or a portion of the beam will exit the body. Of course, as in most radiography, a lot of the beam is attenuated such that it never makes it out of the body, and that just contributes to overall CT dose. But as we have discussed, having areas on the image that do not represent anatomy still contribute to the image. In any case, the beam exits the body and strikes these detectors. The detectors are able to distinguish the differences in tissue contrast because they can analyze very small differences in the photon wavelength, in other words, the strength of, or energy of those photons coming out of the body. There are some conversions that need to happen in our detector. We have a conversion of X-ray photons. Ultimately, those photons will turn into a light signal, which then also within the detector gets converted to a analog electrical signal, in other words, a voltage. This voltage then has to travel and be processed in a computer, but before it gets there, because computers don't work with voltages, it needs to go through what is known as an analog to digital converter, or ADC, which is going to convert our voltages into ones and zeros, basically our machine code or binary code with which our computer can utilize that for reconstruction. And this may look a little bit complicated, but this is pretty much all of what happens. Here's your tube. Here's your x-rays. Your patient would be over here. And these little rectangles represent your detectors. So very quickly, and the promising part here is that this is a video and you can listen to this over and over. Your voltages come out, as we mentioned before. So to backtrack for a moment, the top portion of the detector has a scintillator material, which is any material responsible or has the ability to convert an X-ray into a photon of light, not a photon of X-ray. After that, our light is converted into an electrical signal, our voltages. Those voltages come out from these tiny little wires. They're very little signals. They reach the amplifier where they are increased. They then go down to a sampling and hold area, which is where our reproduction process is actually technically beginning. As mentioned earlier, those voltages need to be converted into information that a computer can work on, so that's where our analog to digital converter comes in. That binary code goes into a fancy computer known as an array processor, where we do our reconstruction. Ultimately, we are going to create a digital image based on lots of pixels and lots of voltages. At this point, I'm not going to discuss the right side of this, but the right side of this schematic discusses how we get our tube to start, to be controlled, to utilize the correct kilovoltage, MA, and time. And ultimately, our image comes out basically in the form of what's known as a matrix. Sorry about the Windows 8 popping up here. But our matrix just consists of a lot of tiny little squares. In a 512 by 512 matrix, you would have 512 pixels, or what's known as picture elements, going down the x-axis, and another 512 going down the y. And if you multiply the two of them, you get somewhere around 262,000 pixels. Now remember, each one of these pixels is a flat surface that you will see on a screen. Right? So this does not talk about any element of depth, but this is where your grayscale, whether it be white or black or anything in between, will be forthcoming. Ultimately, when we put all these pixels together, we get our image. Our image then needs to be displayed. There are a lot of fancy monitors that can do this. We have a workstation monitor and in the CAT scan suite. And of course, once the image is processed, there is no need to print it out, as there once may have been. We have PACS, which is our picture archiving and communication system. Our radiologists have advanced workstations, such as the ones on the bottom right here, that allow them to view not only one image at a time, but multiple planes of images, which is what MPR stands for, multiplanar reconstruction. They can view the anatomy in an axial format from head to toe, a sagittal format across the body from shoulder to shoulder, similar to a lateral, or a coronal, which would be somewhat like an AP view going from the nose to the back of the head. These workstations have sophisticated softwares that can be attached to them with which to do other 3D type of work, multi MIPs, maximum intensity projections, and virtual rendering. So when it comes to different types of scanners, we have your conventional scanner. It stops, it starts, it stops, it starts. It's what first came out. There are high-speed units, which are helpful in cardiovascular work. After all, we know that there are issues with motion in X-ray, which show up as a blur. And if you're doing cardiac work, you have that beat of the heart that you really can't quite slow down. Not good for the patient. Spiral helical scanners allow a rotation of the tube while the table is simultaneously moving into the gantry. Right, so we have a much faster scan with a spiral helical scanner. We have the mobile scanners that I mentioned before, which can come outside of a hospital or be brought to an ICU unit. We have CT fluoroscopy, which is not just a CT scanner with an image intensifier unit built into it, but we are talking about a technique where our images are acquired so quickly that you can have a monitor inside of the room and a physician can do something to the effect of a biopsy while hitting a pad with their foot to acquire the next set of images, make a decision right there on the spot whether to perhaps move an instrument into or out of the body or reposition. And finally, dual source, which is having either two X-ray tubes, literally, or the ability to have one X-ray tube that flips back and forth between two different levels of KV. And because of that, we get basically two sets of projection data for every one. So now we're talking about several thousand sets of data, which are going to attenuate the beam a little bit differently because of the two types of KV that are flip-flopping, allowing us to get a different level of contrast. So here's our conventional scanner. Here is a cardiovascular scanner. This is a little bit different. It's also known as EBCT, electron beam CT. Works with an electron gun instead of your typical X-ray tube. Our gun kind of allows the electrons to hit a tungsten target, which then actually come through the back of the patient up the front and hit a detector array. Here's a picture of a nice little mobile unit being used in the operating room. Here is one just looks like it's out at the factory. Spiral CT, as mentioned, allows the tube to make continuous rotations. What happens in spiral CT, though, is because your tube and your table are moving simultaneously, before your tube can complete a full 360-degree, your table has already moved past that point, so you never actually get a complete full slice. However, you don't miss any anatomy because it's like submerging yourself into a slinky or a spiral of wire. Okay, you are getting coverage of the anatomy, but it is not each a continuous slice. CT fluoro is mentioned. Looks like they're working on a cat or a dog over here. Here's our monitor that can be utilized during the scan. Of course, we have to be careful if you are the fluoroscopics, and you must make sure that your hands for example, stay out of the beam. Here is a CT Angio, so this is not a different type of machine, but these are some of the things that we are now able to do with our machines. It's not only a angio to look at the vessels, but you can also notice that this looks 3D, has an element of depth to it, and it is also a coronal view. So this was built originally from axial slices. Now we have basically an AP view of the vessels in 3D. Endoscopy is once again based on collection of data, and essentially we take these axial slices, manipulate them in such a way that we can now literally travel through parts of the anatomy. PET-CT is a fusion study. It's the combination of a nuclear medicine scan along with a CT exam. CT is very good at pinpointing small spots, but it may not see if there is a cancer there. In other words, a type of pathology may not actually manifest on a CAT scan. Whereas on a nuclear study, you can get a sort of blurry hotspot. And the fact here is that because you see something is going on, you don't quite know where it is actually happening. When you combine the two, you have a geographical study from the CT and a morphology metabolic study from the nuclear scan. You put the two together and you get a very dynamic type of study where you can pinpoint where there may be a problem much faster than you would on either study alone. Here's another view, right? If you can see this hotspot here, this is the combination of this area that's kind of hard to see, spatial resolution. And here we see that there's something going on, but it's kind of hard to pinpoint exactly where it's going on. Dual source, we have our two X-ray tubes, A and B, going together simultaneously. And that's where I'd like to conclude. Thank you for listening.